JD is a 74-year-old African-American male who presents to the clinic for routine follow-up. Has a past medical history of hypertension, dyslipidemia, and COPD. These conditions could further be exacerbated by his elevated BMI, as well as his social history of smoking. JD lost his father to a heart attack at the age of 64, indicating that there is a family history of cardiac problems. The patient complains of some exercise intolerances, but presents no headache, lightheadedness, and chest pain, angina, or fainting spells. The patient is cooperative and in no apparent distress. He is alert and oriented to person, place, and time. JD presents with a blood pressure of 158/90, a pulse of 130, respiratory rate of 18, a BMI of 33.2, a creatinine clearance of 90 milliliters per minute. Fundoscopic exams further revealed that some mild arterial narrowing, but no hemorrhages. And the patient has a mild wheeze due to his COPD and smoking, as well as a pulse of 53 beats per minute with regular heart rhythm. The patient has full range of motion and has normal deep tendon reflexes. His labs show that he has a A1C that is within normal limits, but presents low HDL levels at 32 milligrams per deciliter, high triglycerides at 247 milligrams per deciliter, elevated LDLs at 145 milligrams per deciliter, all contributing to his high cholesterol at 226 milligrams per deciliter, as well as his diagnosis of dyslipidemia. Based on the patient's comorbidities, his hypertension is classified as primary and is categorized at stage 1. We recommend addressing his hypertension by discontinuing his current therapy of carvedilol 6.25 milligrams, as it is not indicated for African Americans and may be exacerbating his COPD. We plan on starting the patient on a DASH diet and placing him on amlodipine 5 milligrams, 1 tablet by mouth, in order to achieve a goal blood pressure of less than 140/90. And we plan on meeting up with him again in 4 weeks to reassess his adherence and as well as efficacy. The patient's lipid panel, and as well as other factors such as age, a CSVD score of 52.4%, as well as his high BMI and history of smoking, all indicate that he is a candidate for statin therapy. And his current therapy of niacin of 2 grams by mouth 3 times daily is considered inadequate because it could be contributing to his hypertension and his elevated pulse. The patient falls in the 4th benefit group according to the ACS guidelines for statin therapy and is a candidate for a high-intensity statin. We recommend starting him on rosuvastatin 20 milligrams by mouth daily at bedtime in order to reduce his LDL scores and to increase his HDL levels. Therefore, overall lowering his cholesterol levels and as well as lowering his triglycerides. We anticipate a decrease of more than 50% in LDL levels, and we are expecting the patient to achieve an LDL level of less than 100 over time. We will follow up with him again in 4 weeks to reassess adherence and overall efficacy. Some non-pharmacological recommendations we would like to make for our patient are to decrease weight, therefore decreasing BMI, as well as other comorbidities by exercising at least 30 minutes 4 times a week and reducing his caloric intake by 500. The patient will need to monitor his diet and reduce the amount of bad cholesterol, calories, and sodium intake little by little until he reaches appropriate weight of approximately 170 pounds and a BMI of around approximately less than 25. We will recommend that the patient quit smoking and will monitor his willingness to quit and determine the necessary steps to take from there on for smoking cessation as per guidelines.